This is a panel discussion unlike anything you've ever experienced. Here's how it works. Pecha Kucha, it's a presentation style in which 20 slides autoplay for 20 seconds each, and these folks don't control their slides.
To see the sunset on health disparities, to see the end of inequities in care delivery, and the elimination of poor outcomes for children based on race, ethnicity, or language. Just a little small thing. Despite our focus on anti-racism in healthcare since 2020, the world is not such a different place. Inequities have not been abolished. All of the studies that I cite in the next 6 minutes were published in the last 4 years, and all of the pediatric care settings in which children and families rely on us. There are racial and language disparities in pediatric ED triage. In a 2022 study, despite having similar illness estimates, non-white patients received lower triage scores than white patients. Also in 2022, lower acuity scores were assigned to speakers of language other than English. 2024 study concurred that African American and Hispanic children and teens were often under-triaged, with African American patients having greater than 2 times higher odds of receiving lower acuity scores despite having similar illness severity. There are also racial and language disparities in lab and radiological testing in pediatric ED visits. In a 2020 study, African American, biracial, and Hispanic children were less likely to have lab testing and/or imaging ordered than non-Hispanic white children. There are also disparities in treatment and pain management of pediatric patients in the ED. For example, in a 2022 study, children who are Asian, Black, Hispanic, or spoke a language other than English all had significantly lower odds of receiving IV therapies for pediatric migraine than white children, despite having similar pain scores. As another example of disparities in treatment in the ED, teens and children with asthma from racial ethnic minority groups have higher odds of steroid administration, as well as lower odds of imaging compared with white teens and children, even when we adjust for confounding factors. These inequities are also noted in pediatric surgical care. In a matched sample of healthy children, African American patients had 3.5 times the odds of dying within 30 days after surgery, as well as greater odds of developing postoperative complications and serious adverse events. In a 2023 study, Hispanic children were significantly more likely to die following a postoperative transfusion than white children. Black children experienced 1 and 2.5 times the odds of mortality following postoperative transfusion compared to white children, even when overall health status was taken into account. There are also healthcare inequities in pediatric subspecialties. For example, in 2021, children in racial, ethnic, and socioeconomic minorities were shown to have higher prevalence and greater risk for sleep-disordered breathing, yet children who are white or have private insurance are more likely to undergo adenoid removal and tonsillectomy. And ENT is not the only subspecialty. In 2022, racial and ethnic disparities were shown for Black and Hispanic children with leukemia, including diagnostic delays due to misattribution of vague symptoms, difficulties at obtaining appointments, and financial barriers to seeking urgent care. There are still significant disparities in infant mortality. A 2022 study, infants of Black teen mothers have consistently higher risk of mortality compared to infants of white teen mothers. 2023, Black and Alaska Native American Indian preterm infants had greater odds of sudden unexplained infant death. Nationally, non-Hispanic Black infants have twice the risk of sudden unexplained infant death compared to non-Hispanic white infants. This risk is heightened in metropolitan areas. In the 10 largest U.S. cities, there are higher Black and Hispanic sudden death rates, but lower white rates. Study after study after study of significant disparities in pediatric health care, leading to suffering and even to loss, all published in the last 4 years. Why are we still here? To come out of the darkness, we have to shed light on these inequities. What stops us from doing so? What stops us from progressing? There are institutional barriers, but there are also individual factors such as unconscious biases. As we all know, it's extremely complex and sometimes feels overwhelming to address. So how can we move forward? The first step is to get past the denial that it isn't us. I'm complicit. We are all complicit. We have to own our inequities and face that there may be racial or unequal aspects of our care. If you don't own them, you can't change them. We have to measure our disparities, collect data, and set goals on empirically supported strategies. Two that I'll highlight. First, concordance or matching between physician and child improves health outcomes. And second, standardization of care, such as through clinical practice guidelines, can reduce disparities in care delivery. Then start taking the steps to reach those goals. For example, by building a pipeline of diverse students to reach concordance, by establishing clinical pathways, through implementing communication and implicit bias training, and always looking at everything critically through an equity lens. They depend on us, they hold us tight, and they trust us to keep them aloft. So what are you going to do differently today? What are you going to do to bring back to your teams? How will you step out of denial and into the light of equitable care for all children? So in closing, my hope for an improved pediatric experience of care is to see each of us take individual as well as institutional responsibility to see the sun rise on equitable care delivery and health outcomes. I don't have all the answers, but I'm happy to share my struggles, and we can support each other together on this journey. Thank you.